Management, PPE and isolation, personal protection equipment and isolation. C. Separate documents. If patient suspected of COVID-19, ensure face mask is attached. ASPAS, PPE donned by anyone who is coming into contact. Patient is isolated and contact tracing setup. Majority of patients who remain hypoxic on FM oxygen and HFNO will continue to deteriorate on NIV. So such hypoxemia necessitates early intubation for both patient and environmental safety. Cut off FiO2, that is 0.6 on HFNO. Ventilations. Usually lungs fairly complaint high degree of atelectasis associated with the small airway damage. Use low TV tendal volume according to ideal body weight formula, that is 4 to 6 ml per kg IVW. WHO recommends a high PEEP strategy using the high PEEP ARDS net table in relation to FiO2. Considered early paralysis and early proning if P upon F ratio is less than 150 after 12 hours conventional ventilation for 16 to 18 hour stints. Early APRV has been used in other centers to help alveolar recruitment, particularly if proning problematic. Initial setting HI is 35 cm H2O for 5 seconds, low 0 cm H2O for 0.5 seconds. Recruitment Mansovere appears to be out of favor in current ARDS literature following increased harm noted in recent trials. Assess success of recruitment with prone positioning or APRV using before and after measurements of driving pressure, that is F upon P ratio and lungs compliance. Prostacyclin NIPs commonly used in US centers to improve VQ matching. Allow permissive hypercapnia down to pH 7.1 unless CVS instability develops. Priority is lung protective ventilation using low tindal volumes. ECMO referral. ECMO stands for extracorporeal membrane oxygenation. Usual criteria apply, refers to Papworth, then GSTT, then Harefield with GSTT and Bart's transferring. VVECMO, veno-venous extracorporeal membrane oxygenation if hypoxemia. VA-ECMO if cardiorespiratory failure. Classical spastic shock does not appear to be a common feature of this disease. Avoid volume loading, treat hypotension with low-dose vasopressor, ensure enteric feed, give fluid only if end organ perfusion compromised. Rising lactate, falling urine output, etc. Guided by cardiac output monitoring to minimize the fluid volumes administered. Aim even or negative fluid balance if possible. Avoid NSAIDs. Stop ACEI once intubated. AKI or ARF. AKI stands for acute kidney injury and ARF stands for acute renal failure. Increased risk if pre-existing chronic kidney disease may benefit from early filtration to optimize fluid balance if urine output poor despite high dose diuretics. Extrapolating from SARS. SARS causes renal failure in 7% of patients. The pathology shows acute tubular necrosis, which appears to be a reflection of generalized multi-organ failure. In some cases, rhabdomyolysis have contributed as well. Renal failure correlates with a poor overall prognosis. 92% mortality with renal failure versus 9% without. In multivariable analysis, renal failure was the strongest predictor of mortality, more so even than ARDS. CVS instability associated myocarditis may see elevated troponin on admission with near normal LV function on echo, but may develop late cardiomyopathy associated with sudden fall or in injection, fraction associated with increased arrhythmias, cardiomyopathy associated with 33% of death, rising troponin, a poor prognostic, cardiac output monitoring may help to clarify timing of introduction of intropes. If pH is greater than 7.2, trial of IVH3, aim serum HCO3 is greater than 28, check ferritanin or LDH and HLH. Diagnostic criteria: if positive, consider tocilizumab 1 to 2 doses. Tracheostomy, if required, surgical approach on balance safer than percutaneous in this group of patient. COVID-19 specific treatments. Antivirals under investigation include remdesivir, Caltra, tocilizumab, chloroquine, steroids, and oseltamivir. Remdesivir shows promise when administered under compassionate use program in the US, undergoing trials but not commercially available yet. Caltra, lopinavir or ritonavir is a protease inhibitor which prevents viral replication. Anti-HIV drug easily available, limited evidence of some benefits against MERS but low volume, low quality trials. RCTs ongoing in China currently. Tocilizumab, if massive cytokine release associated with hemophagocytosis and HLH-like syndrome associated with high mortality, evidence basis lacks large number of patients to confirm. Chloroquine interferes with ACE2 receptor and thus virus entry. An expert consensus group in China is recommending a treatment regimen of 500 mg/PO twice daily for patients without contraindications, but this is not supported by any published clinical data yet. Steroids. Steroids do not appear to be generally used. Steroids have not demonstrated benefit in prior SARS or MERS epidemics. Steroids may increase viral shedding. Nearly all articles recommend against the use of steroid, but if severe host response pneumonitis as judged from rising CRP or ferritanin late in disease, some centers in China using methylprednisolone. Oseltamivir, influenza is still common, may be used like CAP antibiotics until respiratory virology or sputum MC and S test result come back. Criteria for de-isolation: 2 negative aspirates 24 hours apart, sensitivity of PCR test proportional to quality of sample obtained, ETT aspirates more sensitive than NPA or throat swabs. Because of lack of PCR sensitivity, 75%. If HI clinical suspicion despite negative PCR, would recommend senior clinical review for final decision regarding de-isolation.